Good evening, everybody, and welcome to our webinar on MS and stem cell. This evening, we are absolutely delighted to be joined by Dr. Maria Gaughan, who will present on the topic of MS and stem cell. And we've had great interest in the topic, and we're absolutely thrilled to have Dr. Gaughan with us to explore this area. We're also delighted to be joined by James Flanagan. James is a person living with MS who has gone for stem cell therapy. He's going to share with us his personal story so we can hear a little bit about his personal experience as well. I would like to thank our speakers and to all of you for joining this evening and for taking time out of your day for us. I'd also like to thank my colleague Fergal for his support today. We've had a few tech glitches and Fergal has been absolutely wonderful in helping me overcome those today. So thank you. Just a quick outline of the session. What we're going to do is ask Dr. Gaughan to present on the topic, and then we're going to have a quick Q&A with Dr. Gaughan towards the end of that session. So if anybody has questions throughout the session, you can send them through the chat function or through the Q&A function. We were sent some in advance as well, so we'll be trying to weave them in and we'll get through as many as we possibly can, but we do want to try and stick to time as best we can as well. So after Dr. Gaughan's session, we are going to be joined by James, who has kindly agreed to share his personal experience with us this evening. And that is about it for me. My name is Aoife Kirwan. I'm the Information Officer with MS Ireland. And without further ado, I would like to welcome Dr. Maria Gaughan, who is a consultant neurologist in Beaumont Hospital and who is going to discuss the topic of MS and stem cell. So welcome, Dr. Gaughan.
Thank you very much, Aoife. That's a great welcome. I'm delighted to be speaking to everyone this evening. I'm going to go through a few slides on stem cell treatment for multiple sclerosis, but I suppose what I'm doing is a lot of the groundwork, the facts and figures, and a lot of the medical side of the treatment. So I think probably people are going to find James's experience more beneficial than anything I'm telling you. I'm very open to questions, and I think if anyone feels that I'm getting a bit too technical with what I'm discussing, please let me know, or you can let Aoife know in the chat, and we can take that down a notch as well. I know it's an area that people are very curious about, so I've tried to address some of the common questions in relation to it, but again, at the end of the question and answer session, we might have more time to go through some of the things in detail. So we're going to talk a little bit about what stem cell treatment is, how it works, how long it's been used for MS, what it involves, and I suppose the big question and the difficult thing for both people with MS and their clinicians is who's most likely to benefit in identifying that at the right time. And then in Ireland, what's the pathway for stem cell treatment? So stem cell treatment is around since the 1990s for autoimmune diseases, but it hasn't been used commonly in autoimmune diseases at all. It's not just been used in MS, it's also been investigated in other autoimmune conditions. So a condition called chronic inflammatory demyelinating polyneuropathy, which affects the nerves of the feet predominantly and also the hands sometimes. A condition that's very rare called stiff person syndrome that Celine Dion has recently disclosed that she has herself, and some rheumatology conditions as well. Why hasn't it been more used for MS is one of the questions, and up until around about 2005, it was actually considered a pretty dangerous treatment, and we have some data showing that the risk of dying during the treatment was actually as high as about 1 in 25 to 1 in 30, during the 90s and early 2000s. So for a long time, it wasn't seriously considered as a good treatment option. And also, it was seen for a long time as a treatment of last resort. And we've learned recently that that's not when it's of most benefit to people. So we weren't seeing the results as good as we would hope for. But I think it's probably because it was being used too late in the condition. And then the other issue is that while there has been some research, there really hasn't been enough to demonstrate it as a really good treatment. And in particular, what all treatments need when we're using them for multiple sclerosis is really a randomized controlled trial. So anyone who's on any of the disease modifying treatments for MS, they would have all been through very strict and rigid randomized controlled trials before they've been approved for treatment. And up until recently, that hasn't really been available for stem cell treatment. Now, there's been a couple of changes in that. There's been one randomized controlled trial that I'll mention later, and there's a couple that are ongoing at the moment that we hope will have results in the next couple of years. So what are stem cell treatment and what is AHSCT? So stem cells are cells that renew easily and they can become multiple different cell types. So they've a lot of potential that can become any different cell in the body. In particular, embryonic stem cells, so the cells that we all develop from when we're a blastocyst and we're just a few cells that are implanted into our mother's womb. They were made of stem cells and they gradually divide into nerve cells, muscle cells, cardiac cells and blood cells. But when adult stem cells can only divide into particular cell types, so hematopoietic stem cells divide into different type of blood cells. When we talk about autologous transplant, that means your own cells are being transplanted back into you. In a lot of treatments for cancer, they talk about allogenic transplant, so that's when somebody else's blood cells are donated to you, and that would be used for some types of aggressive cancer. So in cancer, it can be used in leukemia, lymphoma, and myeloma. And again, as I mentioned, autologous versus allogenic transplant. So in multiple sclerosis, it's predominantly or always autologous because the risks of getting somebody else's cells are quite high, and you would need to be on very strong doses of immunosuppression to allow that to take effect. So the stem cells can divide into the platelets, white cells, and red cells. So the results were mixed, as I mentioned. There were high rates of complications, particularly in the early days, and then the mortality, as I mentioned. Now, looking at what changed and when do we consider that is some data came out over the last probably 6 or 7 years that really changed the way that we looked at stem cell transplant as a treatment option. So one of the things they've done is that every person who's had a transplant in an approved centre, generally in the world, the data on that is recorded. So there's been about 700,000 stem cell transplants done internationally up until about 2020. But as you can see here, for autoimmune diseases, there's been about 2,500. So it's pretty uncommon even for stem cell transplant. Within that, the commonest reason they're done for is multiple sclerosis. So up until 2018, about 1,200 transplants were done for multiple sclerosis. That number is increasing fairly significantly over the last few years, but I don't have the recent up-to-date figures. So in 2017, Paolo Moraro, who is one of the neurology consultants who is really the chair of the London group, that anyone who's been considered for a transplant in the NHS in the UK, Paolo Moraro chairs the group that's responsible for that. He did a really detailed review article of all the people who had been transplanted for multiple sclerosis. And he was able to show in that review that when he looked back at the data, people were doing pretty well. And in particular, the people that were doing pretty well were the people who were younger and the people who had relapsing remitting MS. And up until this point, the majority of people who were going for transplant actually had progressive MS. But he was able to demonstrate quite clearly if you were younger and had relapsing remitting MS, you could actually do very well from transplant. They were also able to show that after 2005, the mortality risks associated with the transplant went way down and were less than 1%. Around the same time, Maria Gaughan also did a meta-analysis demonstrating rates of no evidence of disease activity after transplant of about approaching 70% in this group of people who had both progressive and relapsing remitting MS. And when you took the people with relapsing remitting MS alone out, the rates of no evidence of disease activity after 5 years were about 83%. So this was considered excellent, particularly when you look at the people who would have been going for transplant if you'd relapsing remitting MS were probably people whose MS was a little bit more active or a little bit more aggressive. For people who aren't aware of the terms, I'm sure a lot of you aren't, no evidence of disease activity is kind of considered one of the gold standards that we're looking at in research now. So we're not just looking at whether or not you have a relapse, and we're not just looking at whether or not you have a new lesion on a scan, and we're not just looking at whether or not things might have progressed a little bit with your mobility. we're looking at all of those things together. And if you've got all of those things where there's no new relapse, no inflammation in the scan, and you feel that everything is the same and unchanged over a few years, that's what we call NIDA. And even some of our best disease-modifying treatments at the moment, the NIDA is probably closer to 50%, maybe 55%, rather than the 80% that was seen in this study. So as I mentioned, there's been one clinical trial done, and this was done in the States, and the results were really excellent for transplantation versus the best available disease-modifying treatment at that time. So this was a really detailed study done by a clinician called Bert, who's been an advocate of transplantation in the States for quite a while. The problem is that when he did the study, the best available treatment was natalizumab, predominantly. So there was no B-cell therapies available. There wasn't even alemtuzumab available, and cladribine, Mavenclad, wasn't available yet either. So the question was, how would transplant do if all these other medications were taken into account? So at the moment, there's a trial going on in the States, predominantly the States, but also a couple of international trial sites called the Beat MS trial, and there's a trial going on predominantly in the UK called the Star MS trial, and the London group, Sheffield group, and other sites in the UK have really been trying to get as many people as possible involved in this trial so that we can answer the question, is transplantation better than other available treatment that we have at the moment? Okay. So this study is looking at a group of these trials all together, and one of the most important things is the outcomes. So that when you look at this range of different trials, you can see the outcomes are pretty good. So the average follow-up in most studies was in and around 5 years. Some studies were a bit shorter than that, some were a bit longer. And again, if you go down to the percentage NIDA here, the NIDA rates 69%, 78%, 88%, but some of them were also lower, 60%, 30%. When you go up here looking at this, attack-free and MRI-free were 100%. So that suggests this is a really good treatment for relapse, a really good treatment at stopping new lesions on a scan, but maybe not quite as good at stopping progression. So there have been a couple of small trials, and people sometimes wonder, what if I used HSCT at the very, very beginning? And actually, if your MS is very, very aggressive, which is a really rare thing, and that would mean that you have multiple severe relapses within the first months to year after being diagnosed, and you're getting a lot of disability within a very short space of time, you can be considered for transplantation as a first-line treatment. And there was a study of a group like this. The average age, I know it was 28. And if you look here at the number of relapses, so they had, some had eight of the people involved had 2 relapses in the last year, 9 had 3 to 4 relapses, and 3 had more than 5, and none of them were making a full recovery from these relapses. And the EDSS was 5, and that means they were having fair bit of difficulty in mobilizing after these attacks. But when HSCT was used as a first-line treatment in this group, the patients did exceptionally well. One of the challenges is that if we saw somebody like that, we would rarely wait to do HSCT as a first-line treatment because it can take a little bit of time to get things in play. We would probably put them immediately in hospital within weeks on a very high efficacy disease-modifying treatment, but HSCT could still be used here as a second-line treatment if the first-line treatment wasn't working. So one of the big questions that we have is in progressive MS. So again, earlier on and earlier in the transplantation course, the people that were generally going for the treatment were people with progressive multiple sclerosis. And the evidence overall is that that group tends not to do as well and can continue to progress despite that, which is very disappointing, I know, for a lot of people. There's a bit more nuance to it than that, and there has been some research And if you actually, I've circled this, there's a couple of things here. One of the things that can change things around is when you get the stem cell treatment, and I'll go into that in a little bit more detail, you're given a chemotherapy regime to kind of get rid of your current cells before the stem cells are infused back in. And it seems your recovery and how you do, it seems to have an impact on how the severity of the treatment you get to kill off your current cells. And while you'd imagine that if you were given very strong treatment, that would be better, but actually it's been demonstrated that isn't better for probably a couple of reasons. If you're given very strong treatment to kill off the cells, that can actually have an effect on your brain function as well and make you maybe not do as well. And also you're more likely to get a lot of complications and illnesses, which can significantly impact in your recovery, you know. So very strong treatment, as was done in these trials, and in fact they did some radiation treatment in these two trials. These were done about 20 years ago. Those people didn't do as well. But other groups did do better, had progression-free survival in some groups that would be higher than you'd expect overall in progressive MS. What I would comment on is that the average age is very young. So this is generally in these studies, they've looked at people who are in their 30s. And what we see in the Italian study in particular, which really did have good outcomes, is that people were young, average age of 37, didn't have particularly bad mobility difficulties and had new activity on their scans. So I think they all or almost all had new lesions or enhancing lesions on the scan before they went for treatment. So they still had a lot of activity, suggesting a lot of inflammation, and that's where the stem cell treatment seems to work the best. So because of all the evidence that I've presented here, there has been advice overall that for highly active MS, where the disease modifying treatments that you're on, if they're not working anymore, then people with MS should be given the option of a stem cell transplantation. They can't recommend it though for progressive MS without any active inflammation. For progressive MS with active inflammation, it could be considered as a clinical option, however. And whether or not you can be offered treatment is a lot of different factors in that. And one is the availability of treatment locally, and one is the particular criteria of wherever we're referring to. So what does the transplant involve? So I think you're probably going to get a lot more information on this from James than you are from me. And this diagram is a bit technical, but there's a few different steps. And we're going to talk about the referral pathway initially. But if you're going for treatment, you can travel over to London typically, and we'll come back to that. But you go into hospital and you get a fairly high dose of a chemotherapy, cyclophosphamide usually, and then you get another injection treatment to stimulate the cells to grow, because you need to get loads of these stem cells to grow so that you can collect them, because you're collecting them. The goal is to collect them. The reason you're given the kind of high dose of the chemotherapy is that when you're doing this treatment, you'd be worried about your immune system getting a bit overactive initially and your MS relapsing, you know, so you want to give the treatment to prevent anything like that from happening. So after about 10 days, and it can vary, and when it is, the cells are ready to collect, and you're hooked up to a machine with a line into your arm usually. James will tell you if it's any different. And over the course of many hours, they'll collect the cells. And then you can go home. So you're then usually home for a period of time. They have the cells. Sometimes the cells get treated as well. And then you come back to hospital. And then this is the kind of more hardcore part to the treatment, where you're admitted and you're given heavy duty treatment to really deplete your current cell system before the cells are eventually reinfused, and you wait for the cells to grow again. And during that period of time, you're at very serious risk of infection, and you can get too much fluid in your lungs and your heart, and you have to be very closely monitored, as well as in isolation in hospital away from other people. And this can go on for several weeks. And you can be on strong antiviral treatment and antibiotic treatment to reduce the chance of you getting in any infection at all. and then gradually get to the point where you're able to go home again. But often when you're going home, you will not be feeling that well at all because you've been through this fairly heavy duty treatment. And a lot of people, particularly in the first weeks and early months, generally feel worse rather than better while they're still in that recovery phase. And people find this tough, and there's definitely an area there where maybe some rehabilitation could be put in, but unfortunately we're lacking the resources for that at the moment. People are linked in initially with the haematology team in London, and then after that the care is followed up ideally in your local hospital when you get back to Ireland, and ideally you'd have met the haematologist before you ever travelled to London at all. So how does this whole pathway start? So the first step happens, as you know, in the clinic. So you might bring up the option of stem cell treatment, or your consultant might bring up the option of stem cell treatment. And I've been on the other side of the consultation with both things happening, where I might have mentioned it to somebody and it's a complete surprise. They haven't thought about it before at all, or they mention it. So the reasons that it might be mentioned is if the current treatment you're on isn't working, if you might have had a new relapse recently, we might see new lesions on the scan, or things just don't seem to be going right. And you can discuss that with your consultant, see where you are. And if it's agreed that actually this might be a treatment option for you, then the case is referred to the Irish MDT meeting. So what happens is your consultant might say to you, look, anyone that we think may be suitable for a transplant, or even if you yourself are really keen for a discussion, we can discuss and see. And at that meeting, there's a group of neurologists. It's usually about 5. There's 8 who are involved, and there's usually a minimum of 5 neurologists on the call who are predominantly multiple sclerosis specialists. We usually have a hematologist on the line. We have MS nurse specialists, and we review all the details of the history, previous medications. We have a look at the scans as well. And the question that we're asking at that meeting is this person with MS eligible for the treatment according to the NHS criteria? And are there any other considerations with this person that we need to take into account? So when I say, is the person eligible according to the NHS criteria, after the meeting, we're referring on to London. And before we refer to London for discussion at the London meeting, we really want to make sure that the person is the right candidate. Then when I say, are there any other considerations or other issues to take into account, things that we try to address at this point and we discuss with the person's treating clinician is, has this person considered fertility? Are they planning a family? Do they know that this treatment might affect their fertility? Does this person live alone? Do they have support nearby if they're feeling very unwell after the treatment? What options are there to help with their care? Does this person have any history of, for example, something even like claustrophobia? Would they find the isolation very difficult? So do they have other medical illnesses that we need to take into account as well? We also then look at if stem cell transplant is not a good option for this person, we would always think about, well, what can we recommend instead? So is there another disease modifying treatment that could be trialed? And it could be a case that we might say, look, this person doesn't fulfill the criterion now, things are relatively stable with this current treatment. But if that changes, come back to the meeting and we can discuss that again. If we all agree that somebody should be referred, we refer for discussion at the London meeting. So the Irish meeting happens every 6 to 8 weeks roughly, and we partly base it on demand. So if there's cases that need to be discussed urgently, we can usually arrange a meeting a bit quicker. The London meeting is now happening on a monthly basis. So we can usually get through these discussions quite quickly, but can sometimes delay things as, for example, if somebody has a discussion with the consultant in clinic, but an MRI scan is needed before discussion at the multidisciplinary meeting, things like that can sometimes delay things a little bit. So the question is, what are the criteria for the London group? So a definite diagnosis of MS, and we want to be absolutely sure, particularly because most people do respond fairly well to disease-modifying treatments. So we want to be sure if somebody's not responding, we want to go back and be absolutely certain that this is the diagnosis. Then the age range is 18 to 65, but It would be rare that, or unusual certainly, that someone over the age of 55 would be considered, and you'd have to think carefully about someone over the age of 50. And there's a couple of reasons behind that. One of them is, in the studies so far, that people who are a bit older weren't doing as well, and then the risk of complications is much higher in this age group as well. Disease duration under 15 years, ideally under 10 years, but they will take under 15 years if needed. And your disability score would be recommended to be 6 or under. So ideally that mobilizing pretty well. And then the one criteria that they are very strict on is that there has to be a sign of active inflammation in the MS. So ideally you want to see lesions on the scan before somebody be considered. And as well as that, it's recommended that somebody has had a high efficacy treatment before they go for a transplant. And again, that would be quite a strict criteria that you'd need to have tried something else prior to going for a transplant. But almost everyone that we would be discussing at the meeting would have tried something else first. So the pathway is persons reviewed might be a candidate, refer to the Irish meeting, then if that's agreed, refer to the London meeting. And then at the London meeting, your consultant will come on to that meeting. Even most of the Irish consultants don't normally go to that meeting, but they would specifically be invited to present the case. There's usually 10 to 15 MS specialists at that meeting and probably 5 to 10 hematologists at that meeting. And if it was all agreed that you're a suitable candidate, then if you're approved, you go to see a hematologist in London, because it's the hematology doctors, the blood doctors that are doing the transplant predominantly. And simultaneously, you want the application for the treatment abroad scheme to come through. Now, that's quite particular, and we need to have a lot of supporting documentation to send with that. But to be fair, it usually comes through reasonably quickly. Now, you travel for the stem cells to be harvested, and then you would travel for the treatment and be followed up back in Ireland. So just a couple of words on some of the concerns about treatment. Sorry there. So it is an aggressive treatment, so it can have social implications. As I mentioned, symptoms can be worse in the early stages, and it can have an impact on quality of life. And I think one of the biggest issues is probably that you always want to be hopeful about treatment, but I think it's very important to address the expectations as well, that it isn't effective for everyone. There are complications that we need to consider. And then one of the biggest things that we do discuss with people, and it's an extra consideration, is fertility, and you are going to need long-term monitoring. So this is just a few of the complications that we think about, and the early complications happen to most people. Lose some hair, feel sick, get infections. Sometimes you can get virus reactivations, but you're monitored very closely for that, and that can be treated. For women, losing the period, so amenorrhea or losing your periods after the treatment, would be very common, but that doesn't necessarily mean anything about your long-term fertility. In the longer term, thyroid disease, you can get shingles, and theoretically there's a risk of malignancy. So decades later, it may be an increased risk of cancer, but we don't know a lot about that, so I wouldn't be hugely concerned about that. But the usual precautions that we should take in relation to that: keeping up to date with your screening, sun protection, and all those things. So the fertility side of things, there generally most people who have a transplant, and most women in particular, if you have a transplant under the age of 30, most people preserve their fertility, but some people don't, and we're not going to know who those people are for certain. As I've already mentioned, if you don't get your period back right away, that doesn't mean that you're not going to necessarily maintain your fertility. And some people have become pregnant after stem cell treatment without actually having a period. So if you don't want to conceive in the months after treatment, it is important to use adequate contraception as well. However, it can push it into menopause, particularly if you're in your 30s, and it may mean that fertility is an option for you. And what we've been trying to do as part of the stem cell group and discussing is looking at, is there anything we can do to help people with fertility preservation? And as you probably know, those options aren't great in Ireland. So if you have cancer, you'll be offered fertility preservation if you're going for a transplant, but that isn't the case if you have multiple sclerosis, which of course seems very unjust. So we discuss with people their options. Some people decide they don't want to have a family, but if someone's considering it, then we might recommend egg freezing or embryo freezing if the person's in a long-term relationship, or for men, the semen cryopreservation as well. So it's a lot of the technical, a lot of the medical, but how do people themselves tell us they're doing after transplant? And one of the neuropsychologists in St. Vincent's Hospital has done some work looking at this about how people actually are getting on. And she's also done a review about other studies that might have looked at quality of life, because sometimes we're so busy measuring how well people are walking or whether or not they're having relapses, we're not really properly reflecting on how well they're able to live their lives after a transplant. Hasn't made any difference to that. So overall, people felt their quality of life, and this is reassuring for anyone going for transplant, overall people felt their quality of life had improved, but they did feel in the short term that their attention, concentration, fatigue wasn't as good. And then when people discuss their own experiences of stem cell treatment, this like balancing hope and fear. So there's always the hope, and I think when you're going for a treatment as well, a treatment that's aggressive like this, you are hoping it's going to stabilize things. And for some people do get an improvement. So there is always that hope that you'll be one of the people who might get a bit of improvement, and then adjusting to how things go after the transplant as well. And I think one person with MS described it very well there, as you can see in the right. You're like, maybe it'll be me that this is going to work for, and that's very difficult to navigate as well. So in a ideal world, and the long-term view is that we will have a stem cell transplant service available in Ireland for Irish patients who will no longer have to travel for the treatment. In setting up a service, there's a few things we have to consider, and one of those will be patient group involvement, but also that if we're setting up the service, that we have the service adequately staffed from the beginning, because we don't want to set up a service that is going to fail because we don't have everyone involved that we need to have involved to make the service work effectively. And I think that's one of the challenges then anyone setting up anything new. We also want to consider individualized patient care, and what we should be measuring. So again, kind of like what we discussed that Laura Davenport's work in the previous slide. So to make sure we're measuring more than just the medical outcomes, we're measuring, patient quality of life measures, and people with MS, the outcomes that they consider important to them, and are those being addressed in the transplant. So when should someone with MS think about HSCT? So if you're on a strong treatment and you've been told by your doctor in a strong treatment and you're still having a definite relapse, now I suppose clarifying that it is a relapse rather than a relapse that might happen if you're sick or if you're tired or recurrence of old symptoms. But if you're getting something new that's happening despite being on an effective treatment, having new lesions on scan, and then it's important to consider family support, the risks and family planning, and then having something, I suppose, an alternative. And the alternative isn't necessarily a bad alternative. HSCT may not be the best option for you, but there might be something that offers you an improved quality of life as well. And what are those options there, and can that be considered? So for James is going to provide you with more patient-focused experience, and if somebody with MS who's been through all this. But the MS Society of Ireland, the MS Society UK, and the MS Trust UK all have really good patient stories. People with MS have been through the experience, and they describe how it's been for them, and some of the stories are very positive and some of them are less positive. I think it's good that they do provide a range of experiences. We all hope people are going to do really, really well, and that isn't always the case. So I think it's good to see a range of experiences, and there's also a really nice little video on transplantation and the process of transplantation on the MS Trust website that you could review yourselves in your own time. And thank you very much for the opportunity to speak to you all today, and I'm much welcome any questions. I'll just stop sharing this now.
That's wonderful, Dr. Gaughan. That's been fantastic. It's great to have that information for our community around the evidence, the criteria, the pathway, the issues, and the kind of considerations that people might not have considered as well. It's fantastic information for our community to have, and it's so empowering. So, thank you so much for the presentation itself in terms of the delivery, but also the time that you would have taken to put into making it as well. We've had lots of questions, as you can expect. So we'll try and get through as many as we can, but we do want to be mindful of your time. So one of the questions that came in advance was from somebody wondering, like, how best can they actually raise the topic with their neurologist if they have been thinking about stem cell, but it's not something that's been brought up in clinic?
So I think, especially over the last 2 or 3 years, and I think since we set up the Irish meeting, and that was one of the reasons we set up the Irish meeting, was I suppose to increase awareness among Irish neurologists about this option for patients, for people with MS, that this is something that could be considered, and also to be a bit of a sounding board for someone who mightn't be referring many patients for transplant and mightn't really know the ins and outs and mightn't be as clear cut about the referral data. We've presented a few times now at the National Neurology meeting. So I think most neurologists know a little bit about it and know that they can approach myself or several of the other consultants who are involved in a daily basis and on a monthly or so basis if they do want to discuss a case. So I think if you're I think if in the clinic appointment, if you think your consultant might not know that much about it, about transplants and MS, or you think they haven't mentioned it, I think it's always fine to mention it yourself, because I think there's two sides to it. One is it may be an option, and the other is it may not be an option. So I think and actually there's three sides to it. The other is that it may not be an option right now, but it might be something that's considered in the future. So sometimes with some people, if I'm thinking about their care, I'm like, okay, yeah, no, definitely not thinking transplant right now. But if down the line things change for that person, that is a topic I would bring up with them, at that time, if this disease modifying treatment doesn't work. But I wouldn't necessarily bring it up at an earlier appointment or initial appointments. But if it's something that somebody had in their mind, I'd be very happy to discuss that and say, oh, that's so interesting you brought that up. I don't think it's the right option for you right now because you haven't tried something else. So I think we need to go with something else, for example. And then if that isn't working, absolutely, that'll be back on the table and we can look at that again. So I would just be very frank and say, oh, look, I've been hearing about, people say this to us in clinic all the time. I've been hearing about transplant. I've been hearing about stem cells. Is it something that would be good for me? And absolutely bring it up. And your consultant might be like, oh, I have to think about that, or I hadn't really considered that in your case because blah, blah, blah. And then you can be like, that's fine. Or you can be like, oh, actually, I think I might be suitable because of this reason. So I think, again, it's just being informed, and people don't feel challenged by you asking, it's absolutely fine to ask. And if you're, if they're not sure, or if you're not sure, you can ask your cases discussed at the Irish MDT, and we'd give our opinion then based on that.
Thank you.
I hope that helps.
Yeah, absolutely. We've had two questions in relation to the kind of cutoff of the criteria that somebody has to be less than 15 years diagnosed. So we've two questions on that. So could you maybe just comment on how strict that element of the criteria is and maybe the rationale?
So the rationale, I think, again, is in the reviews that they've done. We know that the inflammatory component is stronger earlier. And we know that people do better if they're treated earlier in their condition. But, excuse me, if you were in and around the 15 years, certainly, I mean, we have discussed people who've been 16, 17 years. If they're having definite relapses and if they have definite new inflammatory activity in the scan. So I think the duration is sometimes a bit flexible if all the other criteria are being met, so if you'd had lots of recent relapses, you've been on natalizumab or you've been on ocrelizumab, and you've got 4 new lesions in your brain scan and you've a new spinal cord lesion, then absolutely, if you were 16, 17 years, you'd be considered, particularly if your mobility was still reasonably good.
Okay, and that's actually a good segue into the next question, which is somebody who had asked, what if you have no new lesions, but your mobility is getting worse? Would that be
So,
considered?
yeah, and unfortunately, the answer to that is almost always no, and the
Okay.
reason for that is they feel that if there's no, so that would suggest maybe more of a progressive MS. So that group overall don't do as well. And within the progressive MS group, the people that we know who are benefiting the most are the people with inflammation on the MRI scan. The people who don't have any new inflammation on the MRI scan tend not to do as well, So overall, it's not considered really a good option for that. And even going back to from the presentation I did, that European bone marrow group, it's not recommended for people who are progressing but have no new evidence of inflammatory activity.
Thank you. And one of the questions that came in advance was to ask if there's any research on MS or on stem cell and MS with primary progressive MS to date.
So it's ongoing. And again, it would be, I suppose, a similar question in that, like when they talk about progressive MS, and they're not really talking about secondary or primary, what they're talking about is inflammatory activity.
Mm-hmm.
So I think if you were early in it in the clinical course, and if you had a lot of inflammatory activity, it may be an option, but I think it would be debated very carefully, and that would be very much considered on a case by case basis.
And thank you, Dr. Gaughan. And I suppose the presentation tonight and kind of many of the questions have really kind of been in relation to people accessing stem cell through the NHS and in consultation with their neurologists here in Ireland. Would you have any advice for people who might be considering commercial access to stem cell in other countries? So we've seen a rise, let's say, in kind of advertisements around these things, and we think it would be interesting to see the kind of advice that you might have for people who might be considering that.
A really difficult area, and in a lot of ways, I find very hesitant to advise one way or another, because I understand why people go, and particularly if they don't fulfill the criteria here and they're really hoping to access elsewhere. What I would say is that in an ideal world, if you were going commercially, to try and go to a JACIE accredited centre, so it's JACIE, and that's the quality assurance, I suppose, of the transplantation centres. Now, there's a lot of, you can look that up online, the JACIE accredited centres for bone marrow transplantation. So that group will go into the hospital and have a really rigorous look at how the transplants are done there. And that would give you a lot of reassurance about quality and safety. But I'm pretty sure that most people who go aren't going to those centres. I think if you're going, link in with your local services if you can before you go. So most Irish centres now are approachable if you tell them that you're going. So I know in the past people might have experiences where they felt very dismissed or they were nervous that people wouldn't follow them up anymore. Now I think we more of the approach that if you're going, that's fine. It's good to be linked in though with your local hematologist for follow-up when you get home. The one area it can be tricky is that if the centre overseas recommends things for your local hospital to do that they may not be happy to do. For example, specific scans at specific times with contrast. But you can have that discussion as to why your team may not be happy for that, and there's often a rationale. I think if you're going somewhere, have a good understanding of what treatment is offered there, because sometimes people go for what is described as a stem cell transplantation treatment, but is really not what we would expect would be given in the NHS. So I would ask the centre, what exactly are you doing? So are they giving strong immune treatment when they're collecting the cells in the first place? Are they giving you a chemotherapy regimen to ablate your immune system? What regimen is that? And then you can actually look up the protocols for the sites in the UK and the sites elsewhere, and you can see if it's similar to that. If you can find their safety data, I think that would be a really important thing to look at as well. So there's a few different steps. I know in some other jurisdictions there can be a reluctance to follow up people, not actually from a neurology point of view, who've been transplanted abroad. But that isn't the case as often now, and I think there is an increased understanding of people going, and most centres are happy to follow people up after they come back. So don't be afraid, I think, to access ongoing treatment and support locally if you need to.
Thank you. I'm conscious of time, so we're just going to address 2 more questions, if that's okay. And I'd just like to acknowledge lots of questions have come in, and unfortunately, we'd love to have time to go through all of them, and we just can't. But what I would say to people is, if you have any questions regarding your particular case, it would be best to speak to your neurologist about that as well. So 2 final questions. The first one is, sorry, I wanted to find it. For somebody had been told that stem cell only really works for about 5 years, and they wanted to understand how true that is.
I think that we don't have a lot of data in most of, so as you remember from some of the studies I showed there, I kind of highlighted that the follow-up for a lot of them is only averaging about 5 years. What I've seen with stem cells is some people it just works really, really, really well for, and they can get a real long-term benefit. Some people from the beginning it just doesn't really work that well for at all. And then there's another group in the middle where it seems to work pretty well for a period of time, and then a new lesion can pop up again. So it's absolutely not a forever treatment for a lot of people. It seems to be a very long-term treatment for a proportion. I don't think you could put a number like 5 years on it for most people, but I would say most of the research that has been done on it hasn't a lot of follow-up beyond that 5 years. But Palomararo's study, when he looked back at the people that were done for over about 15 years, from the 90s on to the 2000s, he did have a small group who, at 10 years from follow-up, a good proportion of them had no progression in disease activity. So I think that it's very difficult to put a time limit on it, and I wouldn't say to somebody you're only going to get 5 years out. I think it's a very variable thing.
That's a very fair response. Thank you. And the final question then that I'm going to put to you is around the kind of decision making in London. So somebody was wondering, like, are many cases of Irish people who are put forward for this turned down? And if so, like, what are the kind of most common reasons, I suppose, why they will be turned down for this?
So at the Irish MDT, we try to put forward the cases that we think are likely to be eligible for expectation in someone that they are going to get through, they've gotten through our stage and therefore they're eligible. So that's why we review the cases very carefully before we go to London with the cases. So for that reason, the majority of cases are accepted. The main reason, I can comment on the main reason overall in London that people are declined, and that is not enough no new lesions on the scan or not enough new lesions on the scan. And without new activity on the scan, you're just not really going to be considered unless there has been a very clear-cut new relapse. So sometimes maybe a very severe optic neuritis that you can't see anything on the scan, but it's definitely a new event, then you might be considered. But the biggest reason is not having new activity on the scan. Most other things, and then obviously the other one is, have they definitely had a good trial of another treatment? So maybe somebody has been on a treatment for a month and gets a relapse or a new lesion, and obviously that wouldn't be long enough for the treatment to have generally taken effect, you know, so there could be that issue as well. But generally it's not enough definite. So one new lesion on a scan is usually not enough. For the brain, you usually need two, and one in the spinal cord, or one on the spinal cord, you know. So that would be definitely the biggest reason. A lot of the other things, so the age, the duration of MS, they can be kind of discussed on a case-by-case basis, but that's a bit of an absolute.
Brilliant. Dr. Gaughan, thank you so much for being so open to answering so many of our questions. We really do appreciate it. You've been absolutely wonderful in sharing your time and your experience with us, and your expertise with us. So thank you so much once again to you for everything this evening. Thank you so much. And I am going to invite James to join us. So just a quick introduction, and I'll ask James to tell us a little bit more about himself anyway. But James is a person living with MS who is from Tipperary, and he accessed stem cell in consultation with his neurologist here in Ireland through the system in the NHS. So James, thank you so much for joining us this evening.
My pleasure. Nice to be with you.
What would have motivated you to consider stem cell for yourself, or how did you come to the decision to pursue this treatment abroad?
Sure. Well, I suppose, look, just a bit of my story to start with. I'm 36 years of age now, from Tipperary. I was diagnosed in 2014 with relapsing remittent MS, so it's about 10 years ago now this year. So over the years, I was prescribed a litany of disease-modifying therapies. So I got Tecfidera, Rebif, Ocrevus, but I always felt that I was kind of slipping a bit. I was always progressing, always. So I was like, when I say progressing, I mean that maybe my step count each day was getting less, or maybe I could feel my balance getting bad. So I had heard from my father that there was a procedure such as stem cell therapy, and that it seemed to be effective for a big cohort of people with MS. And the type of personality I have, I suppose this is the answer to your question, Aoife, is that like I could live with whatever comes for MS, whatever MS is for me. But what I couldn't live with is if I didn't do my best, as in if I was to say in 10 years' time, I didn't try something that could have helped, I'd regret it, and that would be a real bugbear for me. And so I was kind of thinking about myself in 10 years' time. Whatever happens, as long as I've done my best, I can live with that. So I suppose that's the answer to your question, if in short, is that I was just doing my best for myself. That's what I thought I should have done.
Yeah. And James, I imagine you would have had like the support from your neurologist and so on. Can I ask about their involvement and maybe their support in kind of guiding you through the decision-making process for that, and particularly as it was abroad?
Sure. So I suppose my neurologist knew for a number of years that I was aware of stem cell therapy, and I had kind of raised the topic a few times in our sessions. But the neurologist was always of the mindset that I wouldn't have been suitable for it, or maybe it was too early. And I'm delighted to hear Dr. Gaughan said that it's becoming more and more popular now, or more and more of it's more available to people now. But when I was first thinking about it, when I was first raising that with my neurologist, it wasn't. And so I was kind of doing my own research. But yeah, like I said, my neurologist was a bit hesitant, was kind of a bit anxious, but I was doing my own research, I suppose. But look, after a number of months and years, I was able to say, look, my walking is getting worse. I've done all these DMTs. I see that I fulfill the criteria to some degree. And what do you recommend? Can it be done? And so, yeah, my neurologist was saying, look, James, they were always telling me for years that to avoid going for the commercial route, because exactly like Dr. Gaughan said, that maybe there's an element of danger there. There's an element of maybe a lack of aftercare. And so I suppose that was a concern for me. I was worried to some degree, but also commercially, there's a huge cost, obviously. So I was like, if I can get this, if I can get approved through the Treatment of Fraud scheme, it's definitely something I'm interested in. So my neurologist said, basically talked me down through the exact criteria there that Dr. Gaughan talked through, the number of active lesions you have to have. You have to try so many disease-modifying therapies. And my neurologist was just incredible. Like, I suppose my disease, like that person who raised that question there, I didn't have like loads or really obvious active lesions on my brain or spinal cord, but I had a few that were not really obvious. And because my neurologist was so good and so helpful to me and knew that I really wanted to go for this treatment, my neurologist actually suggested that I go for a very high contrast MRI to show up these lesions and really advertise that I have active MS, really active MS. And I suppose the results would be posted to Dr. Herrera in London, and the decision was made. And so, yeah, I absolutely have to say that my neurologist did everything she could, everything she could. Yeah.
Mm-hmm. That's wonderful that you had that support, James. But I imagine it's still kind of quite a daunting thing to kind of prepare, I suppose, for going for that kind of procedure abroad. And I'm just wondering, what kind of steps would you have taken, I suppose, both medically and logistically, before traveling to prepare
Okay,
yourself?
so I suppose, sure, yeah, sure. So like, I suppose this goes back to really the time when I got my stem cell transplant. This was the biggest impact, or biggest factor for me. It was in late 2021. Now, I know it's a distant memory for most now, but we were going through COVID-19. And I suppose getting access to hospitals, access to airports, it was really, really difficult. And it took a lot of planning. But yeah, we just about made it work. Very, very strict criteria. But we had to plan stringently for the flights and accommodation as well. But before the travel, I suppose for me, I was like myself, I knew I was going to be very weak when I came back from the treatment. So I wanted to be, I suppose, as strong as I could possibly be before I left. And also I wanted to, I suppose, hit the ground running. Excuse the pun, when I get back. I really want to get back into my fitness regime. So that's basically what I did. So what I did was I went to my my primary care. I went to my physiotherapist. I did a baseline physiotherapist, I suppose, just overview of where I was physically. And that was my goal for when I got back, was to get back to that as fast as I could, get back to that level. So that was how I prepared, I suppose, logistically, and I suppose I was kind of preparing before I left. I was preparing for my return, but yeah, I suppose in addition to that, then like say flights and accommodation, COVID-19, that was all very, very difficult, you know. But we got through it. Loads of support, lots and lots of family support, loved ones, friends. That's really key to everything, especially to something like stem cell therapy. It's really difficult, and having to travel to the UK is very, very difficult, especially when like COVID-19 was prevalent, but also when you're weak with MS. but even doubly so again when you're coming back and you've just been through stem cell therapy. You have MS, stem cell therapy, and COVID-19, which is not as relevant anymore, thank God.
That it must have been such a challenge to manage all of that at that time, particularly. And I mean, when you're talking about having a team here in Ireland and then a team in the UK as well, how did you manage that coordination between the two? And were there any challenges with that?
Yeah, I suppose like there was challenges. But first of all, first and foremost, I have to say, like, the NHS are just unbelievable. Like, the level of care that you get in the NHS is just, it really, like, I wouldn't knock the HSE at all, especially the staff. They're just amazing. But we've all experienced having to go to a hospital. But if you have to go to a hospital in Ireland on the weekend, like, it's a nightmare. On the weekends, you're not going to meet any consultants. Forget about it. But in the NHS, it's the same. And Monday morning is the exact same as a Saturday night. You could access a hematologist, a neurologist, a radiologist. This goes on. It's all there for you. It's absolutely fantastic. So they're really good. As well as that, they had there was an application on my phone that they installed for me, and they gave me a password and login as well. And I said I mean the NHS, the team in the UK. So whenever I got a scan or I got a blood test, the results came straight to my phone, literally hours later. It was just incredible. They were really, really good. Like, I've had blood tests here in Ireland, 3 months ago. I don't know what happened to them. I hope I'm okay. So, like, I really don't know. But in the UK, with the NHS, it's really, really strong. But obviously, you asked the question there about how do I keep the NHS in communication with my own team. I suppose, look, I was sending updates to my own neurologist, my own MS nurse, but also, like, the NHS team would be plugged in with my own team in Ireland as well. So it's all very good. I would just add that it's also important to keep your own GP informed of what you're doing. So, like, obviously advising that you're leaving to go for this treatment, and that when you come back, you've done the treatment. Make sure that your neurologist is sending the test results for your bloods, your scans, your MRI scans, all that is going to your GP. Because if something happens and you're home and you have to go to your GP, well, like, you're not going to be going to your neurologist on a first thing on a Monday morning. It's your GP you're going to be going to, and they will want that latest information. So I think that's a very important part of communication.
And can I just ask about your team here, James, and how they've been involved in the kind of ongoing monitoring and kind of post-care treatment on this side? And what kind of follow-up was necessary then once you got home?
Yeah, so, like, the NHS, they kept me on. I still get notifications on that application they installed on my phone. And only 2-3 days ago, I actually had a follow-up consultation with the hematologist. So I suppose, look, I had the treatment in December. I finished the treatment in December 21, but I'm still constantly linked in with the UK NHS, and they're asking me, how are you doing? Is there any improvement, any deterioration? You can tell they care, even though it's been years. They want to know, which is really, really good. It's encouraging.
And James, did you experience any challenges yourself then when you came home? It's quite a big thing to kind of take on, and particularly, I suppose, when you're in your 30s and so on. Did it have much of an impact on you once you kind of came home post-treatment?
For me, I'm one of those possibly unlucky bunch that Dr. Gaughan had mentioned. I didn't really feel any improvement. Not only that, I'd say my symptoms have probably worsened. I wouldn't say it was because of the treatment, just it's the nature of the disease, but it's like my step count has deteriorated constantly. So it's a constant push, you know. But like it's more so, probably more important. Looking back now, if you were to ask me, would I do it again? I would say I would do it again. I think like I would do it initially for the same reason that I told you at the start. I do it just to say I've done it. I've done my absolute best. There's nothing else I could have done. But I could only do it because I was eligible. So like, if I wasn't eligible, or I suppose if it wasn't safe, I just wouldn't have done it. But I suppose, yeah, like, going back to your question, impact on my symptoms. Yeah, no, I said my symptoms have gotten worse, all right. But look, I'm mentally, I'm very strong. I have great support around me. So I suppose I just getting on with life, you know.
And that's important to, you know, to have that kind of mindset. I'm just going to just say James has actually said that he's happy to take a few questions if people do want to send some through the Q&A. James, I'm just going to highlight that a friend of yours has actually messaged into the Q&A just to let you know that they're watching on. And I suppose just if anybody does want to send in questions, we'll just hold that open there for a minute. But my final question really, James, for you is, like, based on your experience, what advice would you give to somebody who's living with MS, who's considering stem cell treatment abroad, and what should they be aware of, I suppose, in preparation? And I suppose I put this in the context of if they were kind of to go through it in a similar way to you, it wouldn't be fair to ask you to comment on people accessing it in a different manner.
Sure. I suppose my advice to someone who's thinking of going for stem cell therapy, I suppose, look, do it for the right reasons. Don't do it because it's silver bullet and you're expecting some world of stars. Do it just because, I mean, the science, I mean, there's a chance. But do it because, also because I suppose you just want to be able to look back and say you've done your best. But look, I suppose it's important to not forget that, like, I suppose physiotherapy is really important. Your mental health is really important. Talking to people is absolutely essential, and your diet is important. So don't just take on stem cell therapy and neglect everything else. Trying to keep a balance. Everything is important when it comes to MS. You know.
Thanks, James. So a question, James, is in relation to Dr. Gaughan's presentation and the kind of the steps that she would have outlined in the process of kind of going for stem cell and what it entailed in terms of the kind of tests, the kind of harvesting of the cells and so on. Can you speak to that in terms of, like, was that your experience, or was it any different?
So, like, yeah, no, that's right. So, like, I went over to the UK twice. So the first time was for the stem cell harvest, which basically entails like a very strong dose of chemotherapy. And for me, it was to, I suppose, release the stem cells from my bone marrow. And so it meant that I had to arrive on day one, get the chemotherapy, and then I think it was about 2 weeks later, you go through a process called apheresis, and it basically spins out the stem cells out of your blood. And like Dr. Gaughan said, it takes a few hours, but it's two weeks between start and finish. And again, like, you're not going to be going home. Well, for me, I couldn't, because I suppose it was COVID, and it was too much of a risk. So it could mean that you could have to stay in the UK, and you could have to seek accommodation, which is not covered by the treatment abroad scheme. Treatment abroad scheme will cover your flight over and your flight back, and possibly some company, a carer maybe, but it doesn't really cover any of those additional costs that you don't really think of. And I suppose just on that point, I suppose it probably cost about, I don't know, roughly, it could cost about €2,000 or €3,000 of my own personal money just to get the treatment done, because between accommodation, because London is so expensive, you know, and that isn't covered by the treatment abroad scheme, like I said.
Yeah, I think that's a very fair point to raise as well. James, you've another message in here from a friend of yours who says that they were messaging you back in early 2022 and you gave them great advice on WhatsApp about sorting out Uber Eats. So thanks for all your support back then.
That's very important, actually. That's very important. Thanks for reminding me, actually. So yeah, that was one of the struggles. You asked me about one of the challenges. I suppose, look, the NHS is fantastic, but hospital food is hospital food, and it's just, yeah, it's not good. So I think it was during the treatment, one of the nurses said, James, we noticed that you're not eating your food. And I said, look, I tell you what, I just don't fancy the food. I don't know, wild sausages they're not my favorite. So she said, have you ever heard of Uber Eats? So yeah, that's basically what happened. I figured out what Uber Eats was, and I was eating Belgian waffles at 12:30 in the day for dinner. So had a great time after that.
A question in, James, asking if you do feel any benefit from the treatment and if you're glad that you did it.
I mean, any benefit from treatment? Okay, so I can comment on the symptoms I had at the time, and I can say that they've worsened, but I haven't got any, I suppose, how can I say it? So like, for example, I never had any problems with my eyesight. I still don't have any problems with my eyesight. So like, in that sense, I can say that, yeah, maybe it stopped any problems with optic neuritis, but my step count has definitely deteriorated and my legs are not as strong. I used to do a lot of cycling, so it's definitely deteriorated in that sense. But like, if you come to a crossroads and one road goes left, one goes right, you'll never know what the road right would have had for you if you go left, if you know what I mean. So I would do it again if I had to. I would do it again.
James, I'm just going to finish up there, just mindful of your time and you sharing your personal experience. It's not an easy thing to do, and it's much appreciated. Telling your own story and kind of sharing so much of your personal experience is difficult, and we really, really do appreciate it. I think it's really enriched the session and given people a far greater kind of insight into the topic of stem cell. I just want to highlight as well, as Dr. Gaughan would have kind of highlighted, there are lots of different experiences with stem cell in terms of how people access it, in terms of the experience they have, the kind of outcomes that they feel they have, and so on. That can really vary. So I suppose it's just important to kind of recognize that as well. So look, I would just like to bring the session to a close and just once again thank you, James, so much for your input and your contribution to the session. Dr. Gaughan, again, thank you so much for your wonderful contribution as well.